I just should introduce myself. I'm one of the upper GI and bariatric surgeons at Salford. From my point of view, I have been a consultant for 7 years, and I've previously worked in Coventry and Liverpool as a consultant. Most of my medical training before I became a consultant was based in the Liverpool area. Now, what I've been asked to speak to you about tonight are really the options available in terms of the bariatric procedures we've got available. And I thought we could just have a brief introduction to each operation. I could go through it and tell you the advantages and disadvantages of each as I see it, and then perhaps we'll have some question and answers at the end. So if you could bring up the next slide. So increasingly commonly, the most commonly performed bariatric procedure is a sleeve gastrectomy. And when we do a sleeve gastrectomy, I don't know if you can see my cursor, but if you look at the area of the stomach, so as we work down from top to bottom, you'd see a tube coming down through, and if we take that as in its entirety, that's the shape of the stomach. Now you can see that by doing an operation, we can turn the stomach into a tube, and the main advantage that gives us in terms of weight loss is that it massively restricts the amount of food that somebody can eat in one meal. And what that means logically is that people eat far less, and we get impressive weight loss by reducing the size of the stomach. So we would think of that as a restrictive procedure. One of the beauties of it is that it's very straightforward to do. In some ways, you could say it's more physiological in that it keeps the gastrointestinal tract more normal. You know, it keeps a route from top to bottom all the way through with no interruptions, and we see patients get significant benefit from it. Should we just try the next slide? So what many people would traditionally call the gold standard bariatric operation is a Roux-en-Y gastric bypass. If we, again, could follow the esophagus down to the top of the stomach, you can see that we can use a stapler to disconnect the top of the stomach, and we form what we call the gastric pouch. We then divide the bowel lower down within the abdomen and bring a loop of bowel up onto the gastric pouch. So you can see again that we have got a route down through the esophagus into the gastric pouch and then down through into the small bowel. Now, if we look at where the green arrows are, the bile and the pancreatic juice runs down from the liver and the pancreas and joins into the bowel much further down at what we call the jejunal or the jejunal anastomosis, and really normal digestion as we would understand it begins from this point, so where the black arrow is. So you can see that a significant proportion of the small bowel is taken out of circuit and bypassed, and that means that patients both eat less, so it's partly a restrictive procedure, but it's also a malabsorptive procedure, and patients absorb less of the food that they take in. Should we bring up the next slide? Now, if we were to think about positives about Roux-en-Y gastric bypass, very effective. It probably gives us slightly better weight loss than a sleeve, but results increasingly are comparable. And we see good reversal of type 2 diabetes, sleep apnea, etc., as weight reduces. One of the interesting things about bariatric surgery is as soon as patients have the operation, often we see huge improvement, if not resolution, of type 2 diabetes. And that seems to be a very rapid onset effect. With Roux-en-Y gastric bypass, relatively limited reflux. We can reduce problems with reflux by giving patients a longer loop. But one of the problems with a longer loop is obviously that means that you get less and less absorption of the food that you take in. it's been around for a long time. We get good long-term data from it. Now, in terms of the disadvantages of Roux-en-Y as compared to a sleeve is really that it's more difficult to do. Once patients get beyond a BMI of perhaps mid-50s into the 60s, it becomes difficult. And sometimes we would do a sleeve to try and get some initial weight loss. And once we bring the BMI down into the 50s or even the 40s, perhaps we can convert the sleeve to a bypass at that point. So it gives us the opportunity for a stepped operation. Now, on there, I've got adverse effects. There's risk and benefit to all operations, and particularly with bypass, we can sometimes see ulceration, hernias, and because we've taken some of the small bowel out of circuit, all of the areas of the small bowel absorb different vitamins and different minerals. And so if you think about it logically, some of the small bowel that's been taken out of circuit means that you can end up with vitamin and mineral deficiencies in the longer term. Can we just have the next slide? Okay, so the third operation I'm going to mention tonight is really a compromise. So we've said that a sleeve is straightforward and effective, but in some ways at least, bypass is the gold standard, but becomes more difficult in bigger patients. Now, for some patients, we would go into an operation planning to do a single anastomosis bypass, but essentially from a surgical point of view, we could think of a single anastomosis gastric bypass as a compromise operation if we really want to do a Roux-en-Y, and when we start the operation, it becomes more difficult than we'd expected. So if we were wanting to do a Roux-en-Y gastric bypass, once we started the operation, we see that things within the abdomen are more difficult than we'd anticipated. Sometimes it's sensible to compromise. And the ways we can compromise, we can either compromise and do a sleeve gastrectomy. As results of sleeves improve, it may be that that is all a patient ever needs. And the second way we could compromise is to do a single anastomosis gastric bypass. So if we again look at the right-hand side diagram, we've got some red arrows coming down from the esophagus into the top of the stomach. We make the gastric pouch as we would normally, but then if you look at the green arrows, that's the digestive juices, and you can see that there's just one join where we bring that loop of small bowel up onto the gastric pouch. Now, the main disadvantage of this, as I would see it, is that logically we would see an increase in reflux and perhaps reflux symptoms as compared to a conventional Roux-en-Y. Now, again, if that becomes a ongoing and difficult problem for patients, sometimes at a second operation after some weight loss, we can convert it to a conventional Roux-en-Y. But obviously, from a surgical point of view, what we're looking for is to do the correct and most appropriate operation the first time so that patients get the best possible result. Can we have the next slide? So again, just some advantages and some disadvantages. It is slightly easier to perform than a Roux-en-Y. Slightly lower chance of internal hernias after, because it's easier, it's quicker to do, and studies suggest that it is safe and effective. As I've said on the previous slide, the main disadvantage compared to a Roux-en-Y is that patients get reflux of bile. Sometimes that might lead to ulceration. Again, vitamin and mineral deficiencies are going to be similar, but depending on the length of the bypass and the amount of small bowel that's out of circuit, obviously they could be different as compared to a Roux-en-Y. In terms of longer term data, it's a relatively new procedure, and so we just need to gather some data over perhaps 5 to 10 years and see how it compares to a Roux-en-Y reconstruction in the longer term. Should we have the next slide? So that's really all I've got to say. There are other operations that we can talk about if you'd like to. We could perhaps speak about a band. In terms of bands, really, they are used increasingly rarely. The reason why they're used increasingly rarely is that it's essentially been superseded by the sleeve. We get a lot of complications with bands. We're commonly removing them. And if we're looking, the real role for a band, as I would see it, is something that's simple, which generates some weight loss before a more complex and definitive procedure. Now, since the invention of the sleeve gastrectomy, that's really become the treatment of choice if we want to do a stepped operation. And that's why I've not shown you an image of a band in the presentation this evening. Should we move on to some questions?
Yeah, brilliant. Thank you so much, Mr. Grocock. That was a really good explanation of the surgeries that we offer here at Salford. So I noticed in some of the comments there as well, people were saying that it's their first time here. So I'm really glad you can join us. The idea of our support group is each month we have one of our team give a talk about the service that we have. And this time we're very lucky we have a surgeon and he's talking about the surgeries we do. So each time you come on, you should get a good feel of us as a team and what we do. And then hopefully that'll help you as you're going through your weight management service in making an informed choice if you think bariatric surgery is for you. It's also the time where you're going to spend it's the time where you're going to get the most education around bariatric surgery. I know that I always try and give updates each session. So at the moment, from referral to this service, if bariatric surgery is for you, to meeting our team is actually 1 year. So it's a long time. And this is why it's really important to us that we have these support sessions so you don't feel like you're completely in limbo, that you're still in touch and with us as well. And we're obviously working on those working times as best we can. And then when you come through and meet our team, you'll have some education session with myself and Chris, with the Q&A session as well. You'll meet the medic, you'll meet the surgeon one-on-one so that we can go through things in a much more individual way with you. And have a good idea of the type of surgery that you might go for. You might meet our psychologist, most people do. Yes, this is very much a surgery that's body and mind, and the assessment that they do is really quite interesting for you so that you're kind of mentally and physically prepared for surgery going forward, and it's a good way to just be self-aware about things that you might come up against after surgery. You may also have a sleep study. This is something we look for to see if anyone has a condition called sleep apnea. This would absolutely not stop you having your surgery, but it's worth us and our anaesthetist knowing in the way that we would look after you after surgery. So that's just a little sort of whistle-stop tour of our service and how we work and why we do these sessions. So I'm really glad you could join us tonight. So we will move on to some question and answers, Stevie.
Yeah, perfect, no problem. So we've just got myself and Liam from ABL, if anybody's got any ABL specific questions, and we've also got Saba from More Life. I've just tried to promote her to a panelist, so if you've got any questions specifically about More Life, then please do let us know. So one of the first questions is, how do you decide which surgery is best for a patient and what factors are taken into account?
So from a surgical point of view, some of it is to do with, we take into account what patients want. Some patients come with a very strong view of the operation that they would like. In terms of, from a medical point of view, we're partly looking at the patient, looking at their size, working out how difficult each procedure would be. And then there are things in the medical history which mean that sometimes an operation is not appropriate. So, for example, if somebody has got a significant hiatus hernia or they get a lot of reflux, then because a sleeve gastrectomy increases the pressure within the tube, then that would often make a patient's reflux worse. So we tend to avoid sleeves in patients with bad reflux. And obviously patients that have had a lot of previous small or sometimes large bowel surgery where they would have significant adhesions or disease small bowel further down, then in that group of patients we tend to avoid bypass, because obviously if we're going to do operations which can be difficult, then obviously we need healthy tissue to make healthy joints.
Thank you. So somebody else has asked, are all operations performed keyhole, or is there ever open surgery?
Normally speaking, we would be looking to perform virtually all of the operations keyhole. The advantage of keyhole surgery is greater in bigger patients because for technical reasons, in terms of getting access to what we would need to operate on, bariatric patients would need a much bigger scar than somebody that was slimmer. And so the advantage of keyhole is greater. So I would say 99% of operations are keyhole. There is always a possibility, depending on either what we find at time of surgery or things that can happen within an operation. For example, if we had significant bleeding, then sometimes we might need to make a conventional cut to make sure that things stayed safe. So we, I suppose, reserve the right to do open surgery, but we're very much aiming to do it keyhole.
Thank you for that. Nicola has asked, does the part of the bowel and the stomach that are kind of out of use, do they remain in the body or are they taken out?
So it varies between the two operations. I perhaps should have said that in the talk. But when we do a sleeve, we take the bit of the stomach that's been removed, we take that outside of the body. With a gastric bypass, the bit of the stomach that is disconnected, if you remember back to the image, we had a pouch at the top and then the stomach was underneath. So with a bypass, we leave the stomach in place. Now, what that means if we leave the stomach in place is there's the potential in the future in selected patients to reverse things if we needed to.
Thank you very much. So, sorry, I'm just finding my next question. So what are the percentage weight losses for each surgery? Are they all the same or do they differ?
No, we see a spectrum. We could conventionally think of results of bypass as approximately 60-65% of loss of excess weight. So when we talk about excess weight, we're really talking about the weight that is greater than a patient has got more than they should have. So for example, a patient with, let's say a patient is 25 stone, when their ideal weight would be 10 stone, their excess weight is approximately 15 stones. So with a bypass, if we were to lose 2/3 of that, we're approximately looking at 10 stones of weight loss. So the patient longer term would come down to roughly 15 stones, the 10 stones of normal weight, and then the 5% that they don't lose.
Perfect, thank you. So we've got 3 very similar questions here, one from Helen, one from Adele, and one from John. So what is the recovery time and how long will I need off work before I can drive? How long would you be in hospital? And the very ambitious question from John that I like a lot is, would I be able to play rugby again after surgery?
Okay. Now I'm a typical man, I'm afraid, so I might need to ask you to repeat each one as I go through. But time in hospital, we would normally expect the majority of patients to stay one night. Sometimes people stay a second night. It really, I think most of it comes down to pain. I think sometimes people come for operations and because they know it's almost certainly going to be keyhole, sometimes with pain, it's to do with preoperative expectation. So I think it's worth saying that even though on the outside, the holes might be quite small, you can tell from the images that on the inside, it's really quite a big and quite a significant operation. And there will be some pain associated with it. And if patients expect that, then normally speaking, they manage it better. So I've had a few small operations. I've had my knee scoped, and I would say I would expect laparoscopic surgical pain to be similar to that. My knees were extremely sore the following day post-surgery. It settled or started to settle from the second day post-surgery, and by the third day, I was increasingly back to normal. So realistically, I think we could expect that with abdominal laparoscopic surgery. I think you will be sore post-op. We put some local anaesthetic in at time of operation, which obviously numbs everything. But say as the local anaesthetic wears off, there will be some residual pain. We obviously give tablet analgesia. But yeah, normally speaking, most patients manage it and it's home 24 hours later. The other reason why sometimes people stay in an extra day is if they're struggling with nausea and we're just struggling to get people eating and drinking. That seems to be a little bit more marked, perhaps after a sleeve than after a bypass.
Thank you. And then with regard to the exercise, so John's question was very specific, so about rugby, and then there's a part I missed off the end as well. Would he be able to run a marathon after having bariatric surgery?
Yeah, I would hope so. I mean, in terms of exercise, what we conventionally say is for, I think before we said return to driving. So the rules for driving, as soon as somebody feels safe to make an emergency stop, they can legally drive. Okay. In reality, I think it's sensible to have at least a week off driving and to start with short trips before you go straight back to big trips. In terms of light exercise, we encourage people to be active in the early post-op period. In some ways, that's important because it gives you far less chance of a blood clot in your calf. But in terms of heavier lifting and heavier exercise, such as rugby, it's probably sensible to wait at least 6 weeks until restarting heavy contact exercise. The reason why that's important is because operations are increasingly difficult each time it's done. And for example, if you were to start early heavy lifting and early heavy exercise, you would risk a problem with your wounds and potentially an incisional hernia. And we obviously want to just get it right first time, give you best possible result and best possible long-term outcome with as few complications as possible and as little need to ever reoperate on you again as possible.
Perfect, thank you. Jodie, it looks like you wanted to add something in there.
No, that's fine. No, we've covered it all.
Perfect. Okay, so where's my question gone? It's just moved up the thing, sorry. Oh, Jodie, this question's for you actually. Following on from surgery, is this, if you're worried or you've got increasing pain, is there somebody that you can touch base with? What do they do after surgery?
Yes, so when you're discharged home from surgery, you'll have my number and you'll have the number for the dietitian, but we strategically call you. So we'll call you the week after surgery. Sometimes we'll call you the week after that as well. The dietitian tends to call you as you go from your liquid into puree diet around week 3. And then they have follow up with both of us. The idea is hopefully you never see a surgeon again, because we don't really want you to see a surgeon unless there's a problem. So we're there for you. We both have answer machine in our office as well, so that we try and get back to everyone within the same working week. I think the most important thing is that you have had a major surgery. So if you were getting increasing pain, you were feeling tired, you just know that you're not right, and it's absolutely appropriate to go back to our A&E and make sure that we can reassure you that there's no issues with your surgery so you can carry on your recovery. So we'll sort of prepare you before you'll understand all the kind of things that you might feel, and then if you're concerned about anything, if you were wanting to do, if it was to say a weekend and you're not too sure what to do, then you'd use your 111, you'd use your out of hours GP. If it was something like you were wondering if you had a bit of a chest infection or one of your wounds was infected, if it looked red or angry or hot or anything like that, then it's straight onto the GP and it's, yes, receptionist, this is an emergency because I've recently had surgery. And then you normally get an appointment or a call back that day. And you just have to remember that the world of bariatrics isn't known to all healthcare professionals. So if you're in that liquid phase and you're speaking to your GP and they think, oh, we need to start you on some antibiotics, you have to remind them that you're in the liquid phase and you'd like the kiddie stuff, please, ideally sugar-free, so that you're giving things like the syrups. And just a little, next month we're having our pharmacist come to talk about medications. I think that's a really important one because I think after surgery it can be confusing, what can I have, what can't I have, so do join us for that session, it's really useful. Oh, you're on mute, Phoebe.
did press the button, nothing happened there. So a question that we're asked quite frequently, actually. So what happens to the loose skin? How does that go? So which one of you would like to take that? Is that you, Jodie?
Yeah, I don't mind talking about excess skin. I think excess skin is something that's very difficult to avoid. And obviously depending on what BMI you come from, and how you go through that rapid weight loss. Everybody gets some excess skin initially. You can go to the gym, you can do lots of exercise, that's wonderful, but that won't necessarily impact on excess skin. So that is something that you do need to think about before surgery, because unfortunately on the NHS, skin removal is not offered routinely. So therefore this is something you do need to think about. I know that when we've had some of our patients talk about it that have had surgery, for some it's not a bother to them at all, because they're really happy with the other health conditions that have improved, and it's something that they kind of accept. And for other people it really does play on their body image, and psychologically they don't cope as well with it. So it's something that they're thinking, well, I do need to pay to have this removed. And so these are things you do need to consider when having bariatric surgery.
Thank you. So there's two questions here, one from Cara and one from Ruth. One is, does the surgery stop you from feeling hungry? And the other one is, which method of surgery curbs your hunger the best?
In terms of a run-off study, I've not seen a run-off study between the two. Logically, both should be similar. And the reason why I say both should be similar is that we think one of the main reasons that people feel hungry is to do with ghrelin, and that's released from the fundus of the stomach. So that's one of the objectives, if you like, of a sleeve gastrectomy is to make sure we remove as much as the fundus as we comfortably can. And so, yeah, I would say both similar, really. I mean, the main reason why you stop eating is partly to do with reduction of your hunger, but it's really because both operations, when we think of the way they've been drawn out, there's a significant restrictive component, and there's just not as much space. So as patients eat, they will then automatically feel full.
Thank you. So somebody said that they've read if a sleeve is too tight, you can't swallow or spit. Is that true? And if it is, please could you explain why?
Now, if we think of the image of a sleeve gastrectomy, where we have effectively shape the stomach like a tube, one of the reasons we see more reflux after a sleeve is that we're converting a baggy, loose area into a tight tube. And so acid and secretions from within the stomach and within the duodenum, potentially the pressure is greater and things are forced upwards. Now, we try and make the tube the perfect diameter. I wouldn't say we would make it too tight. It is possible from a technical point of view to end up with a slight twist in the tube, or sometimes halfway down the stomach, there's a natural narrowing, and it's important at that point, halfway down, not to make it too tight halfway. So if we were to say, do we ever see complications after a sleeve? I would say we do. And if we end up with a sleeve that's too tight or doesn't empty very well, the short-term fixes are perhaps to balloon open narrowings, sometimes to stent narrowings. And if we couldn't sort it out, there's the potential with a sleeve to convert it to a bypass.
Thank you. This next question is something that I'm actually seeing more and more in our Facebook support group. So somebody says, I'm desperate for surgery to lose weight and I seem to be waiting a long time. Would you recommend going abroad for surgery?
I think my gut feeling as a surgeon would be to say no. And I'll explain why. I accept that possibly my viewpoint is a little bit skewed. And the reason why my viewpoint's skewed is the NHS, i.e. Myself and the team that I work within, we sort all of the problems out for people that go abroad and then come back with complications. And I think, in my view, if we go abroad, there's a reason why it's cheaper. The reason why it's cheaper is because I think very much it's production line surgery, and you perhaps don't get perhaps the same perioperative and post-operative care that you do if you have it done on the NHS by a team like the Salford team. And I think because things are done in a rush, I would say that the complication rate is higher. Now, if increasingly, we don't know how many patients are going abroad, but I would say that at least 2/3 of all patients that are admitted to Salford with complications have had the operations done overseas. So although the wait is an irritant with the NHS, if you could wait, I think you get better quality care. I don't know if Jodie's got a different view.
No, I think it's a very hard question to answer. And I think that you have to think about yourself as an individual, because the knowledge you have and then going through the process and then support afterwards, if there are things that you it's hard to know if that's something you're going to really, really need. So I think the way we've designed our program is to try and make sure that that's there and available for people. However, it's very much put to your GP once you get back home and they don't have the expertise or the skills in the field. So it's a difficult one. I think it's something that a lot of people have decided to do because you've been in this process, and I think just the fact that you've been in the process and gone through weight management puts you at an advantage in the sense that you're better prepared. So no, I would have to say that I agree with Mr. Grocock. We live very close to Manchester Airport, so we do tend to see a lot of the issues. So again, we do have a slightly biased view against surgery abroad, just simply because it's what our NHS has to deal with all the time.
I suppose from a tier 3 perspective, so a tier 3 service is a prerequisite to being referred to Salford Royal in most cases across the different CCGs. So I work for a tier 3 service, and part of my role is to help you to be ready to have long-term success following your surgery. So it's about behaviour change prior to the surgery, so that in the long term you've got those healthier habits, and that's to do with your activity, your eating habits, just your general day-to-day behaviours. So that's also something that you wouldn't get if you went abroad. You wouldn't get that pre-support that we offer, and then the pre-support that Jodie's team offer, and then the post-support that Jodie's team offer as well. So there's a lot that you're not getting there, and if you do want that pre and post support, that's an additional cost. So the surgery might be cheaper, but then there's additional costs outside of that people don't tend to go for, where I think you probably do need that support in the long term. And I see lots of people coming back into tier 3 services having had surgery abroad and then lost some weight, but haven't managed to keep up the behaviours to keep the weight off long term. So they're coming back for support from us. But it is a very difficult decision, and I appreciate the wait is such a long time and people can feel quite frustrated and almost not in control of their own situation. So definitely consider it beforehand. But that probably takes us quite nicely onto the next question, which is there any psychological support pre and post surgery?
So this is really important because, as I said before, it's body and mind. So we work with all our tier 3 weight management services, and there should always be a psychology aspect in that weight management service. So if you're coming into weight management, and I totally respect why sometimes people feel this way, you have weight issues, you've tried lots of things in the past, you go to your GP, and then it seems like another hurdle or another barrier to having bariatric surgery. But it's a necessary one because it's the only way people get funded for weight loss surgery. And then most people do find a real benefit in it. So I think definitely be open-minded to everything that there is in that weight management service, because access to psychology in our country is horrendous, and we have this readily available for you in weight management. Once you come through to be referred on to Salford and you meet our team, as I say, we tend to have most people, at least 80-90% of people will go and see our psychologist for an assessment. This isn't for therapy, it's for an assessment. So what we don't really want is anything being identified there that should have been worked on before. So we can offer some therapy sessions at that point, but things like binge eating or any kind of eating disorder will never, having bariatric surgery will never resolve that. So they're the things that we hope that in your tier 3 weight management you may have addressed. And just more basic, life is stressful, and as lovely as it is to lose weight, that doesn't mean life will be free of stress. So it's having that kind of toolkit, that emotional toolkit. How will you deal with things if you were somebody who learned a bit more on, right, that's it, I just need some chocolate, I'm really down and I need to do this, I need to do that to feel good again. So it's trying to find other kind of ways of looking at life and approaching things after surgery, just to make sure that you kind of feel ready for whatever life throws at you, that won't be revolving around food and habits that you're desperately trying to change when coming into bariatric surgery. After surgery, sometimes we do find patients that need that additional support, and we'll refer them back to our psychology team. But even then, there are waits with that, which is a shame, but that's the reality at the moment with psychology across the service. So your best opportunity is to get into anything that the tier 3 weight management have, even if you think, oh, I don't need psychology, I'm fine. Have it anyway, you never know, it may be really useful.
I would absolutely second that, Jodie. So the next question is from Maria. I'm on warfarin after a DVT and PE 4 years ago. Will that be a problem for the operation?
Shall I answer that one, Jodie? I suppose the easiest way of thinking of it in all of medicine, really, everything we do is a balance of risk and benefit. And if we were to say, is your blood clotting normal? If you normally take warfarin and stop it in the run-up to surgery, it isn't. So your risk of bleeding, if you're on regular anticoagulants, is slightly higher than if you weren't. But obviously you're taking that medication for a reason. Now, what we tend to do with people that are anticoagulated who need surgery, we would tend to take them off warfarin, move them on to a heparin-based injection, and we need to time the last dose of that heparin-based injection so that you can have a safe operation. And then depending on how easy the operation is, we would then restart the heparin in the post-operative period. Sometimes that's on the evening of surgery if the operation has been particularly straightforward. And equally, if your operation was in the afternoon and it was a little bit difficult, we might give you first dose of heparin the next day. So what we're trying to do is normalize your blood clotting as far as we can, do a safe operation, and then thin your blood up again in as safe a way as we can. Initially, that would be with heparin, and then as soon as we know that you're through the perioperative period, we'd switch you back to your normal medication that you were on previously. Does that make sense?
Thank you. So this next question is one we get quite frequently. So is there an upper age limit for surgery?
So I would say no, there's no definite cutoff. But again, in the same way as we've talked about risk and benefit, the problem as people get older is that they generate additional comorbidities. And so really, it's not about your physiological age, it's about your fitness for a significant operation. And so, for example, we sometimes see patients in the 70s that might have a leaky heart valve, struggle with walking, they've had previous heart attacks, they've got COPD, they may have renal failure. Those sort of patients, we can equally see those comorbidities in patients in the 50s. But again, it's about picking out patients who can have safe surgery. Sometimes as people get into the late 60s, 70s, then if we're weighing the total risk and benefit of intervention versus leaving things alone, it may be that we try and manage things medically in patients with more comorbidities, because the risk of surgery in people with lots of comorbidities is that little bit higher.
Thank you. So somebody has asked, they said they've been given a surgery date for the 26th of September. When do they start the liver reduction diet?
Do you want to answer that one, Jodie?
Yeah, I'll take that one. Okay, so if you've been given a surgical date and you haven't had a refresher or any contact with me or Chris, then please use your contact numbers for us and get in touch, because it would just be nice to go through a few things with you as a bit of a refresher. So everybody's listening, just so you're aware, elective surgery at Salford recommenced, and they focused on all the patients that were stopped way back when in 2019 and 2020. And though there's been support and there's been other things, there's always people that perhaps aren't aware of it, and so on. So if when you come and meet us at Salford, we will go through exactly what a liver reduction diet is. You'll have videos to watch which talk it through. You'll have booklets, so you've got a reference as well, and then you'll have opportunity to ask questions and answers about it. But your liver reduction diet is in the very front of the nutritional booklet, which is the purple and white booklet that you'll be given once you come and meet our team. And you start that 2 weeks prior to your surgery. So do root that out, whoever you are who's got their date, which I'm delighted for. And when you root out those booklets, you'll find our numbers too. But if not, you can ring the main switchboard and ask for me, and they'll put you through, and I'll make sure that I do a refresh with you if you haven't had one already.
One thing I might add there is during the talk about the different available procedures, we talked about Roux-en-Y perhaps being the gold standard operation. For anyone that has been listed for a Roux-en-Y gastric bypass, just to reiterate the importance of sticking to the liver diet as strictly as you can. The reason why that's important is that we need to access the very top of the stomach to make the pouch. Sometimes with people that don't follow the liver diet very strictly, sometimes it's quite hard to access that. And that's one of the perhaps indications where we would consider compromising and doing a sleeve, because we can do a sleeve in patients if they've perhaps not been as strict. Whereas if you're going to have a bypass, it's important to follow the liver diet if you want to have that as your primary procedure.
Thank you. And then along those lines, Jodie, is the liquid and puree food a specific diet to follow, and how long are you on that for?
Yeah, so we ask you to do a 3-week liquid diet after surgery, and then you go into 3 weeks of puree, and then on to sort of soft mashed with a fork textures. Chris will go through this with you. He's our dietitian. He works with Justinia, our other dietitian, and it's all in the booklet as well. So yeah, so by liquid we mean a consistency that you could suck through a straw, and there shouldn't be any bits, so you need to be able to put it through a sieve. And then a puree would be something that's blended down so that it's completely kind of lump and bump free. We're quite strict in the sense that we say we want you to do 3 weeks of liquid, then 3 weeks of puree, but we are all very individual, and we can sometimes go at a slightly different pace. In terms of healing, we want you to be on that liquid diet for a strict 2 weeks, and in the follow-up that I do with you, then sometimes we might say, right, let's sort of ease into puree over week 2 to week 3. So it's just having an understanding of the types of food that you can have in there. After surgery, the most important thing, as well as making sure that you reach that kind of 1.5 litres to 2 litres of fluid each day, is your protein. So it's really important to just gen up on what your protein sources are and where they come from. We do advocate things like milk because it's an easy way to get it, and we put some extra milk powder in there to boost the protein value in it. We don't really want you to ever be on a diet again, so we don't really advocate that you buy meal replacements with added protein in, but they can be fine. Sometimes people may have things like Weetabix on the go for breakfast because it's a nice clear liquid, it's got lots of protein in it and hasn't got too much sugar. So the booklets are really useful, so you can check against things in the supermarket. Is this good for me in terms of sugar and fat content? But protein is absolutely key after surgery, because this is what's part of your repair. Also, your body thinks, oh no, what's happened? I've got into some kind of strange famine, and it will try and hold on to those fat supplies, and it can't exactly. So you kind of shape shift, as it were. So you'll notice that your weight's coming off. You might see it in your face and your neck, and then you'll get on the scales and be a bit confused because it's like, well, I can't really see it coming off there. And that's just because your body at first will hold on to things, and then it has to let it go. And if you have good protein intake, then you will lose weight nicely because your body can see that it's getting what it needs and it's not worried about holding on to your fat stores. So I guess top tip from today, have a look at your protein. And we're super lucky because when you go around the supermarket, you'll notice there's like protein yogurts, protein soups, and all kinds of things that will be super useful for when your surgery comes.
Thanks, Jodie. So Stephanie has said, I have gallstones. Could they be removed when I'm having the surgery? You're on mute.
The answer to that is we sometimes do. Now, I think the best way of answering that question is that we'd probably think about that on a case-by-case basis. And I think my view with it would be that our options are to try and either do everything in one go if patients have got significant symptoms, or to do things in a staged way. Now, obviously, if we're going to take your gallbladder out, it's easier to take a gallbladder out in a slimmer patient. So sometimes we might do bariatric surgery with a view to reducing your weight, with a view to future gallbladder treatment. The only other thing from a technical point of view, when we're looking at the difference between a sleeve and a bypass, if we were to do a sleeve, we've still got access to the biliary tree where we could use cameras to treat gallstone disease if necessary. If we're going to do a bypass, we lose that access to the bile duct and the biliary tree. So that's something else that we weigh. But I suppose in summary, I would say it will be case-by-case decision-making. Sometimes we would do that. I've certainly seen it done. I think, as we've said before, it's about balancing risk and benefit. And it very much would depend on your size, whether you've had previous surgical treatment, how much you get in the way of symptoms, those sort of things. So we could discuss it in the clinic.
Thank you. So this question might be best placed with Chris, Jodie, but I don't know if you know the answer. Would it be okay to continue longer term breastfeeding after surgery?
So in pregnancy, we do recommend that you wait 12 to 24 months after surgery to conceive. And then you can plan any kind of birth as if you never had bariatric surgery. You can breastfeed, and all those things are absolutely there. So no, it's not a problem at all. So I guess I'm wondering if you're talking about getting pregnant after surgery and then breastfeeding, or whether you're breastfeeding and you might be having some bariatric surgery during that period. Which I have to say I've not come across yet, but I can't see any reason why you wouldn't. But I wouldn't want your child to be completely dependent on breastfeeding if obviously you're going to be in hospital and it could be a prolonged stay. So if you're dual feeding and wanting to carry on dual feeding when you return home, I can't see any reason why you wouldn't be able to do that. It would be completely dependent on you as an individual in terms of how well you do with your fluid intake after surgery, because it can take 3 or 4 days for some people to get to that 1.5 litres, 2 litres. And if you're breastfeeding, you're obviously losing fluid that way in that sense too. So yeah, so there's a few things that I would probably want to go away and knock on the door of our physicians and check. But no, as far as I'm aware, there shouldn't be any concerns with breastfeeding and bariatric surgery.
Thanks, Jodie. So somebody else has said they've got PCOS. Will bariatric help with symptoms and infertility?
I would say, in summary, I would expect things to improve with bariatric surgery. I think we can think of reversible conditions associated with obesity as a spectrum. And for example, we've got the strongest evidence for diabetes. What we normally see with diabetes after a bypass is about 2/3 of all patients are off insulin at, say, 3 years. Now, with PCOS, response to bariatric surgery is less than that. But again, I would probably expect improvement, but not complete resolution of symptoms.
Thank you. So Ian has said, I suffer with SVT. I'm on medication for it. Would that mean I can't have surgery? I'm not familiar with SVT. I don't know what that means.